Hello everyone, myself Dr. Devesh Wikhe, third year radiology resident in Krishna Institute of Medical Sciences, Malkapur, Karan, and my topic is role of shear wave elastography as a diagnostic tool in prediction of preeclampsia in the second trimester. As we all know, preeclampsia is a pregnancy-specific hypertensive disorder characterized by new onset hypertension with proteinuria or end organ dysfunction after 20 weeks of gestation. It occurs 2 to 8% of pregnancy globally and remains a leading cause of maternal and perinatal morbidity and mortality. Preeclampsia is associated with serious complications including eclampsia, placental abruption, fetal growth restriction, preterm delivery, and maternal organ failure, making early identification essential. The disease process begins much earlier than clinical presentation with defective trophoblastic invasion, abnormal spiral artery remodeling, and uteroplacental malperfusion occurring in the first and early second trimester. Since classical manifestations appear late, reliable early predictors are required to enable closer surveillance, timely intervention, and improve maternal fetal outcomes. Conventional imaging techniques such as grayscale ultrasound and Doppler velocimetry evaluate placental morphology and vascular resistance but do not assess placental tissue biomechanics. Placental pathology in preeclampsia includes ischemia, fibrosis, and infarction, which are expected to alter tissue stiffness even before flow abnormalities become apparent. Shear wave elastography is a non-invasive quantitative ultrasound technique that measures tissue stiffness in real time, expressed in meter per seconds or kilopascals. Shear wave elastography has shown promise in detecting subclinical placental changes, offering an objective, operator-independent method to identify pregnancies at risk for preeclampsia during the second trimester. Integrating placental shear wave elastography into routine obstetric ultrasound may provide a novel imaging biomarker for early prediction and risk stratification of preeclampsia. The aim of my study is to evaluate the placental shear wave elastography for early prediction of preeclampsia. It is a prospective observational study. The participants included 50 singleton pregnancies in 20 to 26 weeks of gestation. We included those with anterior or anterolateral placenta and we excluded those with posterior placenta or multiple gestation. The technique involved using SWE, using Volusin GE6, using 4 to 10 MHz frequency probe and minimal probe pressure. 3 placental ROIs are taken from which a mean shear wave elastography is calculated. The outcome was to check for the development of preeclampsia according to ACOG criteria. Analysis was done using t-test, chi-square test, logistic regression, and ROC analysis. The ultrasound image of two patients around 23 weeks of gestation. The first patient shows the mean shear wave elastography value of 4.2 kilopascal, which was pretty normal and shows normal placental stiffness with color coding of blue in the lower range of the value. Whereas the second patient shows mean kilopascal of 12.8, which is pretty higher, and also the color is red, which is also higher in the color coded wavelength. And this indicate increased placental stiffness, and this patient developed preeclampsia. Another figure 1a grayscale obstetric ultrasonography showing an anterior placenta with preserved morphology in the second trimester but prior to elastography assessment. On elastography, it showed increased stiffness as we can see the color coded in red. And this patient also subsequently developed preeclampsia. The study population consisted of 50 pregnant women with a mean age of 26.8 years and mean gravid score of 1.6, representing a predominantly young, low parity cohort. This provides a relatively uniform baseline population for assessing placental stiffness using shear wave elastography. On quantitative analysis, the mean placental shear wave elastography value was significantly higher in pregnancies that subsequently developed preeclampsia, with an average shear wave elastography of 1.94 plus minus 1.45 meter per second, and this difference was statistically significant with a pi of less than 0.0001. The distribution curve shows a right skew pattern indicating a subset of patients with markedly increased placental stiffness. On box plot analysis, there is a clear separation between the preeclampsia and non-preeclampsia group, suggesting that increased placental stiffness precedes the clinical onset of preeclampsia. Statistical analysis confirmed that mean placental shear wave elastography values were significantly higher in the preeclampsia group. On logistic regression analysis, shear wave elastography emerged as an independent and a strong predictor of preeclampsia, while maternal age, obesity, and consanguinity did not show any significant association. Additionally, chi-square tests show strong correlation between the screening positive shear wave elastography values and development of preeclampsia. Shear wave elastography provides quantitative assessment of placental biomechanics, enabling detection of subclinical placental fibrosis and ischemic changes, not appreciable on grayscale ultrasound or Doppler alone. The significantly higher placental stiffness observed in pregnancies that develop preeclampsia supports the concept that placental malperfusion and abnormal spiral artery remodeling precedes clinical disease. Increased shear wave elastography values likely reflect chronic hypoxia-induced villus sclerosis and intervillus fibrosis, explaining the strong association with subsequent preeclampsia development. Shear wave elastography demonstrated independent predictive value on logistic regression, while maternal factors such as age, obesity, and consanguinity were not significant, highlighting the dominant role of placental pathology. As a non-invasive, reproducible, and operator-independent technique, shear wave elastography is well suited for integration into routine mid-trimester obstetric ultrasound. Combining shear wave elastography with Doppler indices and biochemical markers may further enhance early risk stratification and screening accuracy for preeclampsia. Coming on to conclusion, placental shear wave elastography is a promising non-invasive predictor of preeclampsia. High stiffness values correlate with early placental dysfunction, enables timely surveillance and management of high-risk pregnancies. Recommendations can be large multicentric validation, include posterior placentas, combining shear wave elastography along with Doppler indices for composite risk model. Thank you.